Welcome to The Bone, the podcast that goes deeper. Here we cut through the noise and get straight to the core of the issues that matter. From real stories to raw truths, we dive deep into the conversations that shape our world and challenge our thinking. We're not afraid to dig in and get to the marrow of it all. Whether it's life, culture, or business in sports medicine, we're here to break it down raw and real. No filters, no fluff, just to the bone. With your host, Shelby Daly, we're getting to the bone. This is a clinically pressed, approved CEU podcast. Find the quiz to gain credit at clinicallypressed.org/courses. Clinically Pressed Company, making the complicated simple through results that give back. Find out more at clinicallypressed.org. Let's get started.
Welcome back to the Bone. Today we're joined by Paul Higgs, an athletic trainer joining us from Valdosta State University in Georgia. He's a trailblazer who has redefined how athletic trainers deliver care beyond the sidelines. Paul is a part of an athletic training-based outpatient clinic where he's helped build a model that bridges the gap between sports medicine, rehabilitation, and performance. So in this episode, we'll explore how Paul has worked and helped create this vision into a reality. His story is an example of what's possible in athletic training when they take initiative and carve out new spaces in healthcare systems. So, Paul, what is your favorite thing about being an athletic trainer?
That's a lot to answer, but thanks for having me today. Looking forward to this. The things I enjoy about athletic training are investing in other people and helping them reach their goals, having an impact on their life to reach the things they want to do. And in the beginning, that was always the patient. But now that I've been in this a while, sometimes that may be the staff member or the peers I work with, or just investing in them to help them become people who can help people. And maybe it's just me getting older, but you see those things and it's all making a difference. And that's what I enjoy.
Yeah. So you've been a clinical athletic trainer, now you're in education, and now you're involved in this outpatient clinic. Can you give us a little bit more background on the Center of Exercise Medicine and Rehabilitation, CEMR? Is that, or do you say it all together?
It's a long name. So we call it CEMR, CEMR.
Okay.
The Center for Exercise Medicine and Rehabilitation is a unique facility in that it is completely housed in the College of Nursing and Health Sciences. So a lot of times athletic trainers might work in student affairs or athletics or even student health. And my place is completely housed in an academic division on campus. One side of the center is a fitness and wellness center that is originally an extension of our exercise physiology program. So the staff members there were certified exercise physiologists. It gave a place for students to come through. And it was open to the public. It's a subscription model, very highly used by the community, and it's open to everybody. And it's a pay-as-you-go thing, and you have highly personalized and very supervised workouts. And then my side of the house was the athletic training clinic. And Valdosta State had the first athletic training major in Georgia and one of the first in the Southeast, and had a program for quite a while. And when our building was built in 2014, I had to see when it opened. And CEMR was part of that process then, but it was to include the athletic training clinic as kind of an extension of that athletic training major. So students could come through, do their rotations, and it gave a way for the public or community to access athletic training services. So there was an AT there. And it gave a way for both sides to benefit, the public to benefit, and it created a little bit of revenue along the way. And nothing wrong with any of those things. Our athletic training major has been retired. We didn't move into the master's setting, so I don't have student interns as much, but it's still a facility open to the public. So I don't see people exclusively connected to the university, but I do see students, faculty, staff, but I see anybody in the community with a physician order. I can see them, and it functions as any other outpatient rehab clinic would run in our community.
Okay. So are you guys associated with the health center at all, or is that where they're getting their written orders from, or is it just general
No, not at all.
written?
It's purely physician. We have to in Georgia. We have to have a physician order or oversight, and the way to document that best. And the clinic is a written order. We can do standing orders or verbal orders, but traditionally in the clinic we have written orders. And I get patients from everywhere. We have two huge orthopedic practices in town. Ironically, both have in-house physical therapy, and I get referrals from both sides. There are plenty of patients to go around. Patients are waiting to get in and want to see somebody, and those, a lot of those people, either one of us could see and do well. So I get referrals from local physicians. I get a fair number of student referrals that, like, we have an upcoming break now, and they'll go home and have their ACL done, not thinking, I'm going to need rehab after this thing. So they schedule surgery during the break, and then in January, I get a call or an email, hey, I've got to do rehab on my knee or my shoulder. Can I see you? I'm like, sure, send me the order. When the doctor sends their protocol. So I get orders from different physicians around the state, and they're just looking for someone to take care of their patients. The patients are looking for good care. I enjoy that part of it where I can keep my hand in the profession. And so it's a win for everybody. I also teach in our health sciences major and get release time for this program. So it's a little of the best of both worlds. And I worked in college athletics for 20 years as head athletic trainer at Georgia College. And I don't miss eating out of a sack at midnight on the bus, multiple nights a week. I do miss a few things in athletics, but the part I enjoyed was teaching, and I enjoyed rehab. And I did get to teach in the very end of the athletic training major when it was here, and now I'm teaching the health science program. So that's a long answer to say that that's what we do, and we're unique that we're not part of student health or athletics or student affairs in any way, completely housed in the College of Nursing and Health Sciences.
Okay. So you're working there. Who else is on the staff that's working with you? Is it students or is it other certified athletic trainers? How does that work?
Right now I'm the only one. So when we had an AT major, I would have students coming through. I have had an occasional intern over the years. I even have worked with graduate assistants, that are working in athletics during the year, but they want to go to class in the summer and would like to plug in somewhere and just see something new. I've worked with them when we had GAs. But right now it's me. So most of our care tends to be one-on-one, but it's nothing to stop people from booking, overlapping appointments. And we learn in athletics to see multiple people at one time and do a good job. So, I like the one-on-one chance to get to know the patient and kind of really address their needs. And they tend to like that as well. But it keeps me busy, and juggling class and clinic time is a challenge sometimes, but it's helpful. It's good.
Yeah. So you weren't the first one running this program. How long has this program been around, and do you know how it got approval? What kind of avenues did it have to get approval through to be implemented?
It's in the building, our health sciences and business administration building is on campus, and that's where we're housed. That's where the major is housed, and the clinic in the center. And so it was planned to be part of this building from day one. Several years ago, I believe 2014, the building opened, and SEMR was part of that floor space. And maybe it took a year or so to get the first person in place. That was Sean Hutchinson, did a great job. He was looking to leave because he and his wife are both from Florida, and said, this is great, but I'd like to go back to Florida. So that's how I found out about the job. And my wife works in higher ed, and she was able she found a job here first, actually, and then I started looking, but that's another whole episode. But it was a collaboration between the existing athletic training program. The health sciences program had not been fully finalized at that point, but the team physician, the athletic training staff said, we want an outlet to keep our people involved in the profession, to keep our students involved in a new way, and serve the community. And so it was never an option, as I understand it, of can we do this? The athletic trainers were doing this already. It was just another way for athletic trainers to do what we're already doing. So the space was built, was drawn into the building. The equipment was purchased, the office space dedicated. I used the same electronic health record system that our student health system uses, but we are separate. So we didn't completely reinvent the wheel here, but it was a chance to just say, all right, we have the athletic training facility and staff in athletics. Let's build a model that can work, for the community. And I think that's probably the challenge a lot of people see is, can I really do that? Like, why wouldn't you do that? You're doing the same thing that you would do in the athletic department. And we've all had to treat the janitor, the custodian, the coach's wife, the coach's kids, the secretary. We treat everybody, in physically active populations are what we take care of. Why would it matter if they're wearing a jersey and carrying a ball or not? We have some of the same needs. So let's do that here. So we're a unique facility in the university system of Georgia. Nobody else in the system I'm aware of has this combination of a fitness center and a rehab facility that's open to the public and completely housed outside of the traditional healthcare settings on the campus.
Yeah. So compensation wise, is this included in, employee packages and the student tuition? Are you still billing insurance? Is there cash pay? How does that look from a business standpoint?
Yeah, the business side of it, you've got to do that. And that's another thing that made it unique here is I don't have to generate enough money to pay my salary and to keep the lights on and pay rent. We're in an existing academic building. I'm employed as a faculty member. So my salary is generally set by tuition and state money, and it's covered. So on both sides of the house of the center, we do charge for what we do, but it's more it adds a little bit of revenue. It is good, but it's also to give some ownership of the clients and patients that come through. We do enough stuff for free in healthcare, and there's a place where we need to give it away, and it may be appropriate, but we don't have to give everything away. And if the patient is paying for it, then they've got some ownership and accountability, and they're likely to buy in and follow the recommendations. So it does generate a little bit of money. We can do some deposits. The patient or client pays online, and we have different services that are listed on our website. And with the physician order, they can sign up and come in just like they would for any other service on campus. And I can chase this rabbit a little further. If we were billing at my last school for quite a while in different things. And we've had third-party reimbursement in Georgia for over 20 years. It's not completely unheard of. Not many of us are doing it, but it is available. And in my last school, I started billing for knee braces. We didn't have a football team, but we had a few people to have ACL surgery or different things, and the physician would write the order for the brace. And if I was to order the brace and go to the local clinic, the typical markup in healthcare was about 300%. So a $300 brace would be billed at $1,000. And then we'd have to pay whatever insurance didn't cover. So what if I ordered a $300 brace, submitted it to the insurance company using the same forms the clinic would do, with the authorization from the physician and all the paperwork, and even if they had really terrible insurance and I charged $600 and they only paid 50%, really bad insurance, then it covered my cost completely.
Yeah.
And if it covered more than that, then I'm ahead on the next brace. And they thought they're getting a deal, and I thought that I've changed the world because I got $600 for a $300 brace. Health fees don't cover everything. Insurance doesn't cover everything. There's stuff that has to be paid for somewhere. And by the way, our student fees don't cover any of the services in SEMR. We're independent, and sometimes students will say, "Well, I thought health fees covered this." Well, health fees go to the health center. We're separate. But I started charging for knee braces way back, and then that led to my daughter had surgery over the break. Can you do a rehab? Oh, sure, we can. And it gave my staff a way to see non-athletes in a sense. The ones that didn't wear jerseys and carry a ball, that were built just like those athletes. Same anatomy, same return to normal life things they want to do. Usually the same age, and it was funny the first time the mom was a physician herself out of town and came with her daughter, did the evaluation. And she said, all right, my copay is $25 a session. She's probably going to be here at least 10 times. Can I just write you a check for $250? Yes, ma'am, you can. Ready to the school. I put it in our foundation account. It was never a question, can you do this? Should you do this? It was, you're providing a care for my daughter. How much should I pay you?
Yeah.
And we forget that's how it works out in the real world. And we think it's different because we work in athletic training or because we work on a college campus. People want to pay for good services and things that are done well. And so started doing a little outpatient rehab on the side. Then eventually we got into filing claims on our athletes for the services we provided there and the preseason physicals. And we did a lot there. So when I heard this job was open here and it's a clinic that's open to the public and, they're speaking my language. This was something I was comfortable with and could do. And like, yes, it worked there, it works in other places. Let's do it in that model. So that's kind of what attracted me to this. And Valdosta State is my alma mater. So it's kind of a special thing to come back and work here again.
Now, more than ever, athletic trainers are becoming inundated with the growing volumes and sources of data surrounding clinical injury management. In fact, the purpose of data has changed. Whether it's pre-participation examinations, electronic medical records, concussion management, nutrition, or wearable devices, athletic trainers are constantly faced with new and complicated challenges interpreting data to drive patient care outcomes, reduce injury rates, and show practitioner value. To get ahead of this change, athletic training departments turn to Preventix, a data analytics solution provider. With over 25 years of athletic training and clinical data experience, Preventix empowers athletic training and sports medicine organizations with tools necessary to quantify the impact of care interventions on patient success and outcomes. As a trusted partner, Preventix works with you to build a strategy that addresses your specific pain points, integrating all your data sources, providing clean, reliable data, dashboards, and metrics that can be immediately accessed by stakeholders at the point of care. Don't let messy, siloed data continue to negatively impact your care delivery initiatives and practitioner value. Unlock the power of your clinical data today. Visit preventix.com for more information. preventix.com.
Raise the bar in 2025. Complete your BOC certification maintenance requirements early. Don't forget that 2025 is a reporting year for athletic trainers. Are you on track to complete your BOC certification maintenance requirements? Find out today by logging into your BOC profile at bocatc.org/BOC360. That's right, it's time, and this year is the year to renew your certification maintenance requirements. Check it out at bocatc.org/BOC360.
Yeah. So with third-party reimbursement, it's not necessarily accepted across all 50 states. In Georgia, what are the pros and cons of third-party reimbursement for an athletic trainer?
The pro is easy. It's a revenue stream, and money will come in if you provide a service and go through the boundaries and restrictions in place by the insurance company and by the Practice Act. It can be a good source of income for a facility. And I have to be sure everything I do is the money that goes to the university, not to me personally. So otherwise I would be taxed on it. We don't want to do that. So it goes to the facility, which is what the rest of us do working out in the real world. We see a patient, the money goes to the clinic. So the pro is it would generate some income. The cons of it is most clinics out in the real world, as I call it, outside of higher ed, they're going to have a dedicated person who can sit on the phone with the insurance company and explain the Practice Act and say, yeah, we sent you that form. We sent you that documentation. Yes, we'll send it again. What is it you need this time? Yes, pros and cons of third-party reimbursement. pros, you're going to make some money.
Mm-hmm.
The con is you've got to have a plan for where that money goes. If you're in the athletic department, and that money should go back to the people who provided the care. It shouldn't go to buying team, uniforms for the other team or rebuilding the dugouts or something. At my last facility, university, this was my year-round fundraiser. So some people had bake sales and car washes and sold T-shirts, and I provided health care. So the other con is, like I said, we don't have a staff that can sit on the phone and chase down the denials and the issues there and say, yes, our law says this, and this is what you're supposed to do, and your policy says you cover these things, and we expect it to be covered. What else, what documentation do you need? Insurance companies are not the easiest to work with, and they do not always go with their written policy, and they're big enough sometimes to say, well, make me. And, if I work for a university, that might be big enough to say, well, this is what you need to do. So there's some cons. In the SEMA, our costs are low enough that it's probably less than the patient's deductible, their per visit deductible. And they're more than happy to do cash pay. And you're seeing more and more clinics of all disciplines go to a cash pay model and not even use insurance. We've got to get away from the idea that our value as a healthcare provider is based on how much insurance will pay us, but it's based on, can we provide care that people want and are willing to pay something for? And some may choose to file it on their insurance policy, and some may choose to write us a check. But so there are pros and cons to it, but there is a belief that in some athletic trainers that if I bill for it, I have to do it differently. And we have to provide the high standard of care if we bill for it or not. The lawyers don't ask, did they charge you for this? No, it was what happened and what should have happened. We have to document it the same way. We're seeing the same people. We work within our Practice Act. We have physician orders and oversight. We're doing it legally and openly. We're not calling it anything but athletic training. We're doing that regardless of if we file a claim or not. So it doesn't change our liability. It doesn't change the process, of the care we provide. It just might change that we have to fill out a couple of forms to get it to the insurance company or to the patient. If I send them a statement or if I send the documentation to an insurance company, it's their bill kind of for services provided.
Yeah. So for traditional athletic training rooms, it's really just the manpower to manage the insurance claims is probably the reason why they don't take on third-party reimbursement.
A lot of times,
is that what you say?
Yeah, it may be they don't have the staff, which means you may have to outsource it to another company who can access your electronic health record and kind of harvest that information and file a claim for you. It's basically how doctors' offices do it a lot of times. An outside billing company, and you split the revenue generated in some form. Smaller staffs, it may be harder to do, but I'm a one-man show, but I'm not seeing 80 people a day or something like a physician's office might do. And I'm seeing far fewer numbers here than I did on an average day in athletics, but I think I'm still providing quality care. So I guess the teaching point, what I say in class is, provide the service. We do have the option for people to file their insurance, with the services here. And if it's this time of year in November and they've met their deductible, it might make sense to file insurance. If it's a couple of months from now, January, and nobody's met their deductible, it might make sense to just pay, as you go. And they've got the receipt. They can use that on their taxes later or show out-of-pocket expense or something.
Yeah. So I guess looking at traditional physical therapy clinics, billing out is the business model for them to get paid. So ethics can sometimes be an issue with how athletic training rooms run. You see, 10 people in 30 minutes. Would those cause any problems or barriers to third-party reimbursement, or does it really matter?
I'm not sure what you mean. What do you mean it could be?
So I guess the ethics portion is with a physical therapy business, you're seeing one person at a time. And so you're billing to create revenue to be able to pay your athletic or your physical therapist, and sometimes there's quotas that need to be met, I would think, in a business model. But for athletic trainers, due to how creative we are, very personalized, if we're not using third party, we have more more freedom on how we develop the programming. I know that there's some I feel like it gets flagged when you submit too many insurance claims. Like, since we see such a bulk of patients within a short amount of time, it wouldn't be a natural, like an 8-hour day at a physical therapy clinic. I guess, would those factors play into third-party reimbursement at all? Maybe I'm making this up in my head, but I'm just trying to streamline how it actually works.
No, there are some companies that require quotas. I've worked for some and say, you're expected to do this much. Mm-hmm. To me, that's unethical. If the patient needs 30 minutes of therapeutic exercise, and that's all they need because they're progressed well into their program, going for another 15-minute round of exercise just because is the unethical part. Mm-hmm. When I worked in traditional PT clinics, we were frequently seeing more than one at a time and still providing quality care. This one may be on a hot pack, while this one's getting supervised therapeutic exercise, and the third one is on the bike, and the fourth one is on ice wrapping up at the end of the day. It's the same thing we do in the training room, the athletic training room. And the only thing that might flag claim is if it wasn't tied to true care, a diagnosis, if it's treatment. Mm-hmm. You can't bill for feel-good stuff. I ice every day just because I ice every day, because I always ice every day, because they tell me I have to ice every day. Okay, what are you treating? How do you know when you got better?
Yeah.
So if it's tied to a diagnosis, and the referral is there, the standing orders that say, if these symptoms present themselves, you can do these things, for this long to meet these goals, then that's true care. You're providing care. Now, there is a place for the feel-good treatment. You need the 20-year-old who has a 60-year-old body needs a hot pack before they go out on the court. Completely understand. Mm-hmm. Am I truly treating an injury or a condition? Yeah, it's debatable. And should I bill for every single ice pack that was ever put on every athlete at the end of practice? Probably not. Some of it's habit. Some of it we're treating here and not here. Some of it has a very therapeutic reason to be there, and probably those should be billed. So it shouldn't be no clinic of any kind in any discipline should just be a mill where we crank out as many charges as we can. Yeah, those get flagged.
Yeah.
But if we're providing appropriate care for the appropriate things in our Practice Act, then we should file appropriate claims. But yeah, there are a few in every field that mess it up for all of us. And that's why things are flagged. People who do it this way may not be doing it right. Let's look deeper. And you find out, well, they're doing a lot of claims because they have 500 athletes. They should do a lot of claims compared to a school with 200. Okay.
So like you had said, there's mental portions of treating an athlete, placebo effects, the feel goods. So since athletic training is in the prevention portion of a scope of care, I know that some third parties are very much more directed towards reactive care after an injury. Are there ways to approach the preventative care and be able to bill out also?
As far as actual care, nothing I know of.
Okay.
Now, most policies will allow an annual physical, and that's probably the closest thing they come to preventive care. And a good preseason physical can qualify for that. Multiple systems are checked with a variety of providers, and it's individualized for the person, and we chase down results as needed. That is a very valid claim to submit. Now, they may only get one a year, and if mom sent them to one at the end of their senior year, and now you're going to see them at the beginning of their freshman college year, they may not be covered. And that's okay, but you still get the information you need. You're going to still see the patient, see the athlete. So as far as preventing things, insurance companies aren't going to pay for something that might have happened. And you can't prove that you fully prevented that thing. But they can show that this happened and this is the normal care provided. So, I mean, like baseline concussion testing, usually not reimbursable, not covered. You can screen people all you want. But as far as I'm providing a layer of information that I might or might not need in the next year, not really billable. But again, you're doing the things you would normally do. But on those things that are billable, we're going to file the claim. Now, if they have a concussion and we're going to assess the severity of that concussion, maybe with that very same type of test, then that's probably a billable claim, billable service. If I have everything else in line, protocol, physician oversight, all those things, now I'm treating a condition. And part of that treatment might be the test or the modality, the exercise, whatever I'm doing.
So for it not to be considered preventative, even if there is, a biomechanical inefficiency, would there have to be symptoms associated with the condition for it to qualify for reimbursement?
Yeah, usually that's how we're going to diagnose or show proof of a diagnosis. There's symptoms.
Okay.
But to say, you have tight hamstrings, and it might lead to back pain or knee pain or whatever. Tight hamstrings really isn't a diagnosis. Patellofemoral pain, low back pain, those are a diagnosis that might have a symptom of tight hamstrings, depending on your philosophies of treatment. But you've got to have a diagnosis. You got to have a reason to see them, and a collection of symptoms usually isn't enough. And if we want to really chase a rabbit, are we treating symptoms or are we treating a condition? And we can treat symptoms all day and never get a person better. We can find the cause of those symptoms and eliminate that cause, or give them the ability to handle, how their body addresses that cause so they can do it better. Now we've made a difference. But if we're just treating symptoms, we're just chasing things that we may never get to the end of it. And it just feels good. And sometimes we have to treat the symptoms until it makes sense. But we're trying to find that reason they have those symptoms, not just validate or prove that symptoms still exist.
Many athletic training rooms use ROIs to validate their care. They usually use the ICD codes to generate a number. Do you have any recommendations on how to better utilize that information? I've kind of challenged that notion of the ROI valuation due to you're not necessarily saving the school the money, you're saving the athlete the money. So is it really saving the school any money? Is it valid evidence to validate evidence for an athletic trainer for their pay or possibly a pay increase?
Mm-hmm.
Do you have any tips on how to structure that information better for an athletic trainer to present to their employer?
Depends on the system you're in.
Okay.
In a high school setting, the school probably isn't paying for the care. Some schools might, and you're not saving the school money. You're saving the patient money by providing that care in-house. And you're probably providing time. So instead of skipping the English class to go to the rehab visit, they could stay on campus, go to the English class, and maybe do that care during PE that they can't fully participate in anyway. Mm-hmm. If you've had ACL surgery, you can usually fully participate in your English class, but maybe not your PE class. But if you're in a system that's not paying for it, you're probably not benefiting. You're not saving money for the school, but you are saving it for the patient, for the families, and say we've saved this much time. We've increased or decreased missed class days by X amount by providing this care in-house. Those are very good things. In a college setting where we may be picking up the balance of that bill, if we were to outsource it and they bill us for something and some of it goes on our school insurance and whatever's left, we have to write a check. Then it might be a valid thing to say, okay, we brought all that service in-house, and this is the money we would have spent off campus that we didn't spend this year. So now you really are saving money.
Yeah.
You've got to be careful, though, now in the world where athletic trainers can bill for services, and more people are starting to see that's a thing. When you say we cover this amount of revenue, we provided this level of care to our community, your administrators may come back and say, well, why didn't we bill for it? And you've got to have an answer. Are we going to be a service organization? And there's a place for that where we need to give away some care. Or are we going to be a revenue producing part of the department? Maybe there's a place for that. So you got to be careful, when what's recorded is rewarded kind of thing. If we keep track of things, we can usually do a better job with it. But that better job may be, well, let's look into this billing thing, And so it kind of depends on the system you're in, if that helps any. But I think it's good to track what you do. We need to. I have known athletic trainers that could, after several years of billing in their facility, would say, all right, I'm consistently generating $20,000 a year. I would like a raise of $5,000. Yeah. Keep the other 15 in the program. We'll wear nicer shirts. We'll buy our own ultrasound. I don't have to show up with my hand out of, can we have money to buy ultrasound? I'll just buy it, out of our budget. But we're providing this care. We'd all like to enjoy and reap those benefits. And other facilities say, we're going to put that money in your budget, not your salary. We're going to expand your facilities and give you more space and more stuff. We're going to invest it in your program. All are good. Just depends on where you are.
Mm-hmm. So we hit third-party billing pretty well, I think. What happens when everybody's healthy and there are no patients coming through your clinic?
Yeah, that's the job security part. As long as people are falling down on a regular basis, we all have a job, which is sad to say. But there are days that it's quiet, and because I am dual appointed in the teaching world and the clinic side, there's always something to do. Now, if we were truly dedicated to full-time staff member on that side of the house that did nothing else but treat patients, that's when you go out back in the community and you just meet your physicians and your referral sources, shake hands, kiss babies, and say, hey, remember us. We'd love to see more people, because there are always patients. There are always people out there. They may not know about you. And there are plenty of patients to go around. And you walk in any rehab clinic, they've got a waiting list a lot of times, especially this time of year when people have met their deductible and they're doing their elective surgeries and they're going to need rehab, eventually. They're all cramming in, running in to get things done at the end of the year, and they're going to need rehab at the beginning of the year. So it may be quiet now while they're doing their surgeries, and it's going to be busy in January, February. But so then it's time for marketing. Then it's time for building new programs, concussion management. Do you reach out to local industries? Do you work on ergonomics? Do you do, a lot of other things? But it's good if everybody got well, but that rarely happens in the real world. With my clinic, I'm closed when campus is closed. So we're coming up on a break now before Thanksgiving. And so it's okay if we wind down a little bit. Yeah. In January, school starts back. I've got to do a little more marketing and remind the physicians we're here.
So when I worked at Caltech, it was a Division III school. We partnered with the health center for orthopedic referrals. We didn't charge. We were doing it for free, I guess. That's the best way to say it. But it was trying to establish a better relationship with the healthcare center so athletes could get in a little bit quicker. If somebody wanted to try to create what you're doing, what advice would you have? Who would you approach about this project? How could somebody get this set up on their campus ultimately?
I think you've got to get away from the idea that it's unique, that we shouldn't be doing this and this is new. It's just, we can provide a service to their community, even if it's just the students. If you just kept it on campus, with the existing people, we don't have to hire anybody new. There does need to be some release time, from other duties, or we just dedicate people there full time. And then you've got to market things. You've got to work within your practice act. So you need to know what your practice act says, not rely on your employer not rely on other peer professions who don't follow our Practice Act, but go in on your state board website, read your Practice Act, and say, I'm allowed to do these things. Why am I not doing them? And at some point, somebody's got to approve it. Everybody has a boss. You go to the dean, you go to the AD, you go to the VP, the whatever, and say, I'd like to provide this service on our campus. And we find we need a space. You're going to have to document everything. You're going to need a space. You're probably going to need some startup tools. If it's just TheraBand and cuff weights and a TENS unit or something, you've got to have a baseline of things to provide that care. And it's just start. I would say just start. Don't be afraid. Don't base it on what everybody else says, but apply what we're doing in other places in the profession to campus. And there's no reason not to. You got to find a way to bill for it. It's okay if we give things away or just provide a service, but that's an expensive service. Somebody's got to pay for it. We're not all working for free. We want to have a salary of some kind. So figure out how do we cover our costs as much as we can, and then what will we do with the revenue? Mm-hmm. But and if we choose to do insurance, great. We've got to get into the networks, and we've got to get the approvals and recognitions, and that's another episode one day. But I would say just start. Don't be afraid to do it. If we're going to start a club on campus, what would you do? Well, we'd hang a sign and say the Great American Athletic Trainers are going to meet here on Tuesdays at 7, and we would do it. If we're going to be English majors, we're going to meet here at 6 and do lunch or dinner. I don't know. If we want to start a whatever club, we do it. And we don't question that. Well, can we really do this because we're athletic trainers? And yeah, you can do it because you're an athletic trainer.
In sports medicine, we talk a lot about recovery, but not all recovery tools are created equal. Mark Pro isn't just another muscle stim unit. It's a recovery technology trusted by elite athletes, athletic trainers, and rehab professionals. Whether you're grinding through tournaments, back-to-back practices, or long clinic days, Mark Pro helps your muscles recover faster, perform better, and feel fresher tomorrow. By improving muscle activation and promoting natural circulation, Mark Pro clears out fatigue and accelerates your body's natural healing without soreness or downtime. Use Mark Pro to stay ahead of fatigue and keep performance consistent, because in sports medicine, recovery is performance. Head to markpro.com and use the code TOTHEBONE for an exclusive listener discount. That's to the bone at markpro.com. Mark Pro, the best in recovery. You work hard. You train hard. You take care of everyone else. But when was the last time you treated yourself? That's where Source Soap comes in. Created by athletes for athletes, Source Soap is an all-natural recovery soap that helps wash away soreness, inflammation, and fatigue. With ingredients like peppermint, eucalyptus, and activated charcoal, it's basically self-care disguised as a shower. Whether it's after a long training session, a tournament weekend, or just a tough day, Source Soap helps you reset, recover, and smell amazing. Because taking care of your body shouldn't stop when you leave the gym. So go ahead, treat yourself. Head to sourcesoap.com and use the code
TTB15. That's TTB15 for 15% off your order. Because recovery starts with you.
With the marketing, how do you explain to somebody that's unfamiliar with athletic trainers what you are, what you do, and then have you received any pushback from any certain stakeholders or parties on continuing your program?
A lot of people don't know what athletic trainers are, and and some of that's our fault. We've kept ourselves in formal sports and athletics, and people outside don't always know who we are. So that was one reason we're here, is to show athletic trainers to the rest of the world. In all of my consent to treat forms and new patient paperwork, it says all care will be provided or supervised by a licensed athletic trainer. We never call it physical therapy or occupational therapy, any of those things. We're very open. This is athletic training. There's a sign on the wall, Valdosta State Athletic Training. That's a kind of a throwback to when we had the major here. And some people ask, what's the difference? I'm like, well, we're another rehab provider. There's physical therapy, occupational therapy, massage therapy, speech therapy. We're athletic training. We're just another sister profession that can provide this type of care. And usually that makes sense to people. They're okay with that. I'm like, well, how are you different? Like, I've only been trained one way. I couldn't tell you what the others do. But I've had patients who have been to another profession, and for whatever reason, it didn't work or ran out of visits or something. And they come to me, and the doctor sends them, and they're like, this is different. I'm like, oh, okay, how is it different? And they have different responses. But if you provide a good care, good service, and people benefit, they don't care what the letters are after your name. Mm-hmm. And if I'm cranking on a patient's shoulder, they really don't care what letters are after my name. Just fix my shoulder and don't do that any more than you have to. If something goes wrong and the physician's going to call and say, why is Mr. Smith's knee swollen? He didn't care what letters are after your name. He invested in this patient and the surgery blew up. What's going on over there? So we get hung up on that. And, but legally, our Practice Act says we're all kind of working on the same level. And so patients will say, what's the difference? And I say, well, we work with physically active populations. That's it. And there's some things, I may get a referral for, like, this is not something I should treat. I'll be glad to help you find another clinic. And that's okay. We should all know what we do well and where we're kind of branching out into the weeds there. And that's what professionals do. I've had a little bit of pushback occasionally from students that are 3 visits in and their knee's better. And then, I send them the email with the link to how to pay their bill. Like, I thought this was covered in tuition. Like, no, it's separate. Or this is health fees. Like, no, we don't get health fees. That goes to the health center. Oh, okay. And then they pay it. I'm like, oh, well, my knee's better. Thank you. I didn't know that. So again, we put limitations on ourselves and say, oh, we can't do it, or that's going to be awkward, and just do it. Be the professional. This is what everybody else is doing it, and we want to be like everybody else. Why do we limit ourselves on these things like this?
Yeah. When I was doing work at Drexel University in Philadelphia, their their fitness center had a physical therapy clinic in it. I guess what would be the pros and cons of having a physical therapist or an athletic trainer on the campus doing this type of stuff?
You're providing care. You're providing service. There are multiple professions who could provide that care. I'm biased and would rather it be an athletic trainer. In a gym environment like that, we specialize in the care of physically active populations, not instead of other people, but alongside those professions. That's going to be up to the employer. But I think in that setting you mentioned, we would do just as good a job as any other, probably better, with some diagnoses and some pathologies. We would be the preferred provider, and depending on if you ask an athletic trainer that question, you'll say, well, you'll hear we're the best. You ask a PT that question, they'll say they're the best. You ask an OT, they're the best. You ask a strength coach, they're the best. So that's kind of a loaded question, but can you provide the service, and can you meet the needs of that population? And we saw a lot of gyms and fitness centers that did that back in the 90s, that people would exhaust their insurance benefits but still want to work on that equipment and have somebody knowledgeable to kind of oversee their care. And you had rehab facilities opening in gyms, and you had performance centers that there was a real blur between, is this strength and conditioning, or is this rehab or therapy, or whatever we want to call it. And it was just all on a big spectrum. That people are here, they want to be here. How can we help them meet that need? And it works well. You just don't file insurance anymore.
So is that where we really benefit, is that we can catch those people that are slipping through the net of insurance isn't covering it anymore? Physical therapy still takes cash payments. Are they just charging more, or how does that work?
Oh, I think that is one way to sell it, is that, we can catch this population. I get a lot of patients in my clinic that are uninsured or underinsured. They're out of state. Their insurance isn't good here, but it'd be great 30 miles down the road in the next state.
Yeah.
Or they're, a mom and pop business with a really high deductible. I've had some that were really economically challenged and had no resources. And I've had high-end attorneys that are basically self-employed trying to save every dollar they can. I work for both of those populations that, need the care and for whatever reason can't or choose not to put a lot of money in insurance claims, but they're willing to pay for a service. We can catch those that are underinsured, not insured. But I just want to see the patients, that if I can help them. And like I said, I get referrals from both big orthopedic groups in town, and they have in-house therapists who do a great job. But at the same time, I can also provide care to a good bit of those patients, and happy to see them. And, and I get referrals from the general practitioners and from the OBGYN and from the, anybody who's treating physically active populations that need rehabilitation. I'm your guy. So, I think that's part of demonstrating that need to the employer, to our campus, is saying there's a population here that needs care that we can provide. They get some care in student health. We can provide that follow-up. We can provide care as a primary care person, maybe on the rec field. We need that follow-up afterward. There is a need that we can meet, and we can legally, ethically, financially provide that need. Where can I do it? On this campus. But we've got to get out of that mindset that it's odd, it's weird. We go 50 feet across the street and there are people doing it in every building around. Why can't we do it on our campus? We can, just nobody's done it yet.
If you were to be the one that started this program, would there be any difference in the structure or anything that you would improve to make your job easier today?
That's a good question. I was the one that started this program at my last school, and it went well. And at that time, probably some of the same things I'm facing here is sometimes it's a challenge in my. Right now, I'm a teacher, instructor, faculty member, and I'm also an athletic trainer in a clinic. And juggling those priorities. And when I worked in athletics, it was practice and games and travel schedule, and occasionally, and I was teaching them too, and I've got patient care. So probably clearly delineating the role of that person to say, what is my job? Put it in my job description, not just release time as needed, but, and we don't want to be the ones that are, back in the day, we worked in hospitals and just, you took care of the school after hours. It was just on you. We don't want to be there. This needs to be while we're hired and part of our job, and specified in there. And then when there is that downtime, you're still expected to fill your time with something productive. If it's marketing, if it's working on budgets, if it's billing, sending out, statements, whatever you got to do. But, probably if I had to do it all over again, or if I was here day one, I would say, let's be very clear in the role of this person so that it protects them, protects the institution, all those things.
Looking forward, how can the profession support athletic trainers trying to incorporate themselves into this type of setting?
I think a lot of it is on the personal level, the individual. We have to own that we are athletic trainers and can provide a very good service if it's prevention or immediate management or follow-up care. And that means knowing what your practice act says, not working for a company and having the boss tell you, who may not have the same letters after their name that you do. They don't understand it. Not letting others dictate what you can do, but knowing what you can do and then advocating for yourself that, yes, I'm allowed to do these things. The profession could be all of our societies and associations. And again, that kind of goes back to the individual. A lot of our associations provide resources to show us how to do these things. If it's continuing ed, or if it's an infographic, or if it's a meeting, if it's a specialty group, whatever it is, but get involved. And yeah, time is tight. When you're working 60 hours and covering practice and games and everything, there may not be time to sit down and plow through some policy statement for an hour. But athletics is cyclical too. There are days we work 12 hours. There are days we work 3, and we get paid the same for both days. Maybe add a little more time. Being a professional is improving your learning and what you can do. And we need to own that and not just say to our associations, feed me, but show up in the kitchen and be ready to cook. Bring some supplies to the table and say, here's what I have. What can I do with it? Mm-hmm. So we're quick to point at other shortcomings, but at the same time, we've got to own some of that. These resources are there. And if they're not there, maybe you're the one that creates it. Or if it's not as good as it needs to be, maybe you join the group that is building it, because they all have day jobs too. We can't all just dedicate a week to create a project, but we can all contribute with the skills and gifts we have to make it better. And then things like this, try to encourage other people. I want to do this thing. Let me find somebody who's already been doing it for at least a year and tell me how. And then I'm at least a year into this. Somebody else is going to ask me, how did you get here? And let me share some things. It's preventive care in a sense, preventing their business and financial issues.
So what's the next steps for your clinic? Are you going to grow it? Is it maintaining? What's the future look like?
It's cyclical. Yeah, it's cyclical. And that's probably one good thing to say too, when you create the service, is know exactly what you're going to provide, what care you're going to provide. As athletic trainers, we're really good at doing a lot of different things, and do we need to provide everything to everybody everywhere? Maybe not. Are you going to just strictly do musculoskeletal rehab? Are you going to work on concussion management because we're experts in care? Are we going to work on, are we going to add a line of ergonomics, desk ergonomics and how to sit at your desk the right way? Are we going to manage, are we going to bleed into strength and conditioning a little bit? Are we going to move into the fitness side? So be very well defined in who's doing the job and what jobs we're going to provide. From my clinic, I think we can get sometimes thinned out a little bit. Do we market for concussions? Do we market for prevention? Do we market for rehab? I've done a little bit of workers' compensation referrals. Do I need to market to the industries and say, hey, we're here, a lot of good providers in town. We'd like to be in network with your people and help them, so the wheels are there. The wheels are spinning. It's just figuring out which direction to go into. Valdosta is a decent sized town. There are a lot of there's a good patient base here in all things. So doesn't really answer the question, I know, but it's when it's slower is when we work on building the business, and then when it's busy is time we do the business, and then maybe we build a little more. So
yeah. Well, if anybody had questions and wanted to connect with you, how's the best way to do that?
Best is the same on LinkedIn. You can email me. I think you get that, or if we post that, it's fine. Probably LinkedIn is where you and I connected, and,
yep.
and different things post and go, hey, have you thought about doing this? And people respond. Happy to help there. As you can tell, I like to talk and I nerd out on some of this kind of stuff, and so I'm happy to talk to other people anytime on these things.
Perfect.
And our clinic is on social media. It's CEMR in Valdosta State. Look at different things there. Facebook, Instagram, all the fun places, and get an idea of what we do. Would love to help other people do these kinds of things.
Yeah. Well, we hit on a variety of topics. Was there any last statements before we close up that you wanted to hit on?
No, I think the biggest thing I tell people is don't be afraid to do this. It's not new. Athletic training has been around for literally centuries. In the gladiator games, there were people who specialized and advocated in good nutrition and therapeutic exercise and massage so that you could go back and fight again in the pit. We've been here a while. This is just one application to use our inherent skill set, things we can already do. And why not do it on campus, just like we would do in other parts of campus, do it everywhere. We do these things off campus. Let's do it on campus. So it's not as weird and awkward as it seems. Just it's got to be done. So you could be the leader. you can be the person that makes a difference and starts this thing.
Yeah. Those are words to live by as an athletic trainer, I feel. Well, thank you so much for being on, and I do hope to have you on to talk more about the insurance, those rabbit holes that we didn't get to today.
We can do that anytime.
Perfect. Well, thank you so much for being on.
All right. Thanks, Shelby. Bye.
That's it for today's episode of To the Bone. I hope we've sparked some new thoughts, challenged your perspectives, or simply reminded you to dig a little deeper. Remember, life isn't just about what's on the surface. Sometimes you've got to cut deeper and get to the bone of what really matters. To the Bone podcast is a product of Daly LLC. It's hosted and produced by Shelby Daly, ATC, and Randy Daly. No clinical decision-making should be based solely on one source. While care is taken to ensure accuracy, factual errors can be present. For more on the show, visit www.tothebonepodcast.com. If you enjoyed this episode, be sure to subscribe, rate, and leave a review. Get involved in the conversation. You can find us at www.tothebonepodcast.com. Drop us topic suggestions or be a potential